I'm going to be going over the Rancho Los Amigos scale. This is commonly used for patients who haven't experienced a traumatic brain injury. Now it's going to start over here at level 1. Level 1 is no response. So when you think of level 1, you think of someone who is in a stereotypical coma. So they're TA, which is total assist. They're dependent. They are unresponsive to stimuli at this point. So they appear to be in a very deep sleep. Okay? Level 2 is generalized response. So generalized response, they're still total assist. They respond inconsistently and non-purposefully to stimuli. Okay, what do I mean by this? If you pinprick them on their left arm, they may or may not respond, and it's not going to be purposeful. So it's not going to be a response to try to move away from the stimuli. It'll just be a random response. The response can be a physiological change. So maybe their heart rate increases. It could be a gross motor change. So their arm flies up in the air, or even a vocalization like ouch or something like that. But it's inconsistent to the stimuli. So it could be a feather that dusts across their arm and they could scream out like they're in pain. Okay, so that's a generalized response. Now, when that changes is when you get down here to localized response. Okay, so localized response, again, still total assist, but now their response to stimuli is specific, but still inconsistent. So, for instance, now if you pinprick them on their left arm, specifically their left arm may or may not, because it's inconsistent, move away from the stimulus, but it is now localized to a certain area. They're able to identify what part of their body that stimulus is, around. So let's use something besides a pain stimulus. Let's say you call their name to the right side of them. They may turn their head to that side in response to the stimulus. They may even respond to a command inconsistently, okay? But this is very low level, very simple, because at this point, they're still total assist. Okay, let's now move on to, we're going to move up to this level here, level 4, confused and agitated, okay? So at this point, they move from total assist to now max assist, okay? The person is max assist, and now they're more alert. They're alert, but they are not oriented, okay? At this point, they're going to respond to internal stimuli of the body, meaning whatever internal conflict or confusion is going on, they respond to that and not much to external stimuli, okay? So they're going to be very agitated, okay? Think of it yourself. If you just had a traumatic brain injury and next thing you know, you don't remember what happened, you just wake up in a hospital with all these people pinning and pricking you and doing this and doing that, you'd be pretty agitated too if you didn't know what was going on and all these things were happening. You're going to respond to what's going on internally, okay? That's all you know, what's going on internally, and it's going to cause you to freak out, and you're going to be very agitated and possibly hostile. At this point, it's very difficult for them to cooperate in occupational therapy intervention sessions for a number of reasons, because they're agitated, because their selective attention is non-existent pretty much at this point. Their short-term memory is very poor. They're not oriented to person, to place, to time. They don't know what's going on. If you're not oriented to who you are, where you are, and when you are, then it's gonna be very confusing and very irritating for you. They're gonna be combative. They're not gonna follow directions. So if you tell them, squeeze my hand, they're not gonna do it because you said it. But at this point, they are able to do some of those lower level functions if they want to do it. They can sit, they can reach, they can sometimes do these things depending, on their physical injury as well. But they can do some of these lower level things, just not on your command. At this point, they're probably going to be trying to remove tubes and different things like that from themselves. So, you have to be very mindful of that at this point. Okay, level 5, still confused, but now no longer agitated. They are inappropriate. So confused and inappropriate. non-agitated. They are still max assist, okay? But the key point for this one is they're going to demonstrate inappropriate use of objects. What does that mean? That would be like you give them a fork and they start combing their hair. Okay, so think of like the Little Mermaid, Ariel the mermaid. She combed her hair with a fork, so that was very inappropriate because she wasn't, in her culture or whatever. But you can kind of think of that to help remember here: inappropriate use of objects. They can perform previously learned tasks, but they need a lot of structure, step-by-step direction. They need you right there with them, telling them how to do it. Okay, so if you think of a self-care task like we'll use brushing our hair again. This is something that they previously knew how to do, but due to the brain injury, they no longer know how. But if you give them that step-by-step, first, hold the brush in your hand. Next, blah, blah, blah. And just take them through it with a lot of structure, a lot of cueing, a lot of visuals. They should be able to do that previously learned task, but they're not going to be able to learn anything new. No new learning at this point at all. They're going to be highly distractible. So with someone in this level 5 stage, they need to be in a quiet environment during their intervention sessions, away from distractions and noise and visual stimuli, just very calm so that they can focus on what they're doing, because their attention at this point is very, very poor. Okay? They can at this point, you'll see a lot of wandering. Okay, so sometimes they'll have like a vague, purpose behind it, like they're trying to go home, but for the most part, it's just kind of vague wandering around. And just a few things that I want to add in about this one. At this point, you'll also see they're going to have difficulty with task initiation. So even though they can do some of these previously learned tasks, that's where this structure comes in. They're not going to initiate it on their own. They're going to need step by step. They're going to need you to be there. But they will, at this point, be able to answer some very concise questions. So during your intervention with them, you want to try to do as many yes and no's as you can and try to keep it simple, because they should be able to answer concise questioning here at this level. At this point in intervention, you can also introduce some cognitive compensatory strategies for them to engage in. And just be mindful here at level 5, you may see confabulation in order for them to fill in gaps. So confabulation is when they kind of just make stuff up. So if they're telling a story, they'll just kind of fill it in with whatever that's not necessarily the truth in order to fill in a memory gap that they have. Okay? Moving on over here to confused and appropriate. So for this one, we're at level 6 now. They're gonna be mod assist. So we're moving from max assist to mod assist now. Okay? But they're still confused, but now appropriate. What does that mean? You're gonna see some carryover with relearned tasks. Still not a whole lot of new learning here, but you'll see for these relearn tasks, they'll be able to carry over and kind of do it with less structure than they required here. Here's all about structure for them, and here they should be able to do a little bit of carryover. They're going to be max assist with newly learned. So again, not a whole lot of newly learned, and if there is, they need a lot of help with it. No carryover for new learn, that's what that says. And then for here, they are inconsistently oriented to time and place, but pretty oriented to self. Okay, so remember up here in all these, there's disorientation to person, place, and time, right? Here they're now oriented to self, but inconsistently to time and place. And then their attention span is about 30 minutes of being able to stay on task. At this level, at level 6, a few things you might see. They can problem solve simple things with that mod assist. Okay, so very simple problems, they can problem solve through them. But they're going to need a lot of help, a lot of external input that's where that monocyst comes in order to problem solve. Like I said, attention is at 30 minutes. Let's move on to level 7, automatic and appropriate. Okay, so they are not confused anymore. Confused was a 3-stepper. They're not confused anymore. Now they're appropriate still, but now automatic. Okay, so at this point they're moving from monocyst to menocyst, and they are independent with self-care. This is huge, huge, huge. They can now do the self-care on their own. They can do these previously learned tasks completely independently, no help. And now they can do new learning. It might be slow, but they can do it. They can accomplish new learning. Something to note at this point, insight is going to be poor. Judgment is going to be poor. They're not going to understand really their limitations cognitively. At this point, because of this, driving is not an option. Okay, if their judgment is poor and they don't really understand what their cognitive issues are, they're not safe to be on the road. A few things to note here: they are, though, going to have increased awareness of their self, their environment, the people around them. So we even move from here inconsistent orientation to time, place, but oriented to self. Now they're even more oriented here, okay? They do know themselves. They do pretty much know where they are, what's going on. Just remember that insight is the problem here. Problem solving is still going to be an issue, but it's getting better progressively with every step. They can monitor their accuracy when they're doing tasks with a little better here. They're still going to need some assist, but they can kind of modify and understand how to do things betterly a little bit more at this level, okay? Moving on to level 8, purposeful and appropriate. So keep in mind the next 3 levels are all called purposeful and appropriate, but the difference here, the differentiation, is going to be the amount of assistance that they need. So that's how we're going to differentiate these. So for this one, you'll see they'll need standby assistance. So they're going to need someone there in case something happens in order to get them out of a situation or help them, figure things out or do whatever they need to do. They're going to be independent with home skills and community skills, which means now they can drive, okay? They have a better understanding of their limitations, but they're still really going to have a very low frustration tolerance at this point, okay? They're going to be able to stay on task for a whole lot longer here, up to an hour, and they're able to tolerate more distractions. So if you remember previously, they needed to be in a distraction-free environment here at this stage, highly distractible. When we get down here, they can be in a busy environment with a lot going on and be able to still focus relatively on what they're doing. Problem solving is a lot better also at this point. All right, now, because I ran out of room, I started moving this way. So it's going to go from here. You see a little arrow that goes here. All right, so this is the next one, level 9. It's, again, like I said, purposeful and appropriate, but the difference is standby on request. So this one here, level 8, was just standby assist. This one is standby on request. So they'll tell you when they need help. That's because they're starting to understand themselves a little bit more here. Their attention gets a lot better. They're able to shift attention between a task that they're doing. They can monitor their performance. A few other things at this point. They are going to be able to kind of, like when I say monitor their performance, I mean like gauge how they're doing. So that's when that understanding of more of their ability comes in. And then you can start to use some assistive memory devices with people at this point as well. Okay, moving on over here. This is the very last step. This is purposeful and appropriate, but modified independent. Okay, so here they're going to be able to kind of think through the process of what's going on in order to prevent problems before they happen, okay? They're going to be able to have consequential decision making. So understanding, if I do this, then this, okay? If I do this, then this is the consequence to that thought process. At this point, they're pretty independent. They're still going to need some, adaptive tools that they're going to use, compensatory methods they're going to be using. They're probably going to need extra time to do things, to complete tasks, but they're able to function in society relatively well. You may see some low frustration tolerance at this point as well, but it'll mostly usually be under circumstances like when they're sick, or if they're just super stressed in general. You're going to notice that it's going to be harder for them to control their frustration tolerance. To review the evaluation protocol as well as intervention strategies for individuals that experience a TBI. So first, starting off, we're going to do lower level Rancho's levels. So this will be levels 1 through 3, which is no response, generalized response, and localized response. For individuals at this level, pretty much they're going to be in a commutative state for the most part. You're going to want to assess their arousal and cognition. By doing this, you can, try to see if they can follow simple commands. That you want to see, can they open, close their eyes? Can they squeeze their hand? That kind of thing. You also want to look at their ability to visually scan or attend. So if they can track something across their midline, sensation, are they responding to external stimuli like pain, temperature, movement of joints? Remember, at the Rancho Los Amigos levels, level 1, they're going to not respond to anything. Level 2, they're going to inconsistently respond to non-purposeful stimuli. So pretty much they don't know where it's coming from. They're not appropriately responding to what kind of stimuli you're providing. But at Localize, they should be. So this is what you're kind of looking for here. You want to see, are they appropriately responding? Is it inconsistent? That kind of thing. You're also going to be looking at joint range of motion. Since they are in a comatose-like state, you want to make sure that you're ranging. You're looking for spasticity, contractures, heterotropic ossification, just making sure that their joints aren't getting stiff from them lying there. Motor control, look for decorticate posturing, which remember is like flexion of the arms near the core. Decurbit posturing is extension posturing. You want to look for reflexes. Do you see, ATNR when you bend one of their arms up? Do you see tonic labyrinth when they're in supine? Are they in extension when they're in supine? That kind of thing. Also look for spontaneous motor movements as well. Dysphagia, are they able to handle their secretions? Are they drooling? Can they swallow spontaneously? Emotional and behavioral factors, is their affect flat? Are they expressive in any way? So if they're in localized response, if they open their eyes, do they have any expression on their face? Do you see any crying or laughing? Assessments that you can use during the evaluation process for levels 1 through 3, the JFK Revise, the WIM, and the orientation log. Pretty much these tools are used so you can document if there's any change in these things that you're evaluating. Visual attention, tracking, can they follow commands? Are there any changes in these? All right, I'm going to go from here and I'm going to skip so that we can talk about interventions for this stage of 1 through 3. So we're going to skip this for now. That's evaluation for the next level. And we're going to talk about interventions for lower level Ranchos. All right, so remember, level 1, no response, through level 3, localized response. Pretty much what you're going to do here, your goal for intervention for them is to increase their level of response and overall awareness of self and environment. You just want to kind of get some arousal, you want to try to get something. You want to get as much function as you can back. So this can be done through sensory stimulation. You want to increase their level of awareness by trying to increase arousal using a controlled sensory input. You can also do, so this is like you always want to try to use something that's personal to the person. So for instance, if they were a coffee drinker, you could get coffee grinds and do a morning intervention where you're, waving coffee grinds in front of their nose to try to arouse them, to try to, get a response out of them because that's something that was familiar to them before their accident. Kinesthetic input can also be used in an attempt to facilitate volitional movement. what you're going to do is you're going to actively guide the person's movements while performing a functional activity. So pretty much an example of this is, let's say in the intervention, you're brushing hair. So remember, at this point, they're pretty much comatose, so they're not going to be able to do it themselves. So you're going to hand over hand guide them through this kinesthetic movement of brushing their hair, because you want to try to reactivate that neural pathway that they had previously. So kind of doing that pattern of brushing their hair to remind the body that this is what it feels like to do that. Bed positioning, side lying, semi-prone. You're going to do these positions for someone with posturing, decorticate, decerebrate that we talked about earlier, or just abnormal tone in general. So lie them on their side or put them in a semi-prone position. It's going to normalize that tone. It's going to give them some sensory input. And then we talked about some of these reflexes earlier, the tonic labyrinth and the ATNR. So by putting them in this sideline or semi-prone, you're less likely to initiate those primitive reflexes that they shouldn't have anymore. Because remember, tonic labyrinth is supposed to go away around 6 months, and ATNR typically goes away between 8 to 12 months in infancy. So definitely don't want to see those anymore. Casting and splinting. So you're going to do this for their spasticity if they have limited range of motion or some soft tissue contractures. One keynote I wanted to put in here: cast one joint at a time. Why do you need to do this? If you're casting multiple joints, so let's say you're trying to cast the elbow, the wrist, the fingers all with one, it's more aggressive, or it's more like pressure points. So like it's more likely to cause a skin breakdown. It's just too many joints being covered and too much pressure on that part of the body. Serial casting is pretty much where you're going to try to increase their range of motion when you see contractures form or spasticity. So let's say you have a person with really bad spasticity. You're going to put a cast on or a splint or whatever, and then it's going to stay on for a couple of days. Then you're going to remove it and immediately put another one on. But before you put it on, you're going to push them a little further out of that posturing. So let's say they have flexor tone. You're going to put the first cast on, leave it on for a couple of days, then try to extend that arm out a little bit more, put a cast on, and then keep going until you're progressively getting rid of that spasticity by getting that range of motion back. A resting hand splint could also be used. It's going to be worn when the patient is not involved in active movement or functional tasks, which is pretty much level 1 to 3. So if you think about it, they're comatose, so they're not going to be doing a whole lot of functional tasks. Same thing down here with anti-spasticity. You're going to want to use this when the person's, not doing a whole lot of functional tasks and moving around, because with these splints, they can't use their hands. They're more of like a protective splint so that they're not getting contractures in their hand. The anti-spasticity splint is for the hand and wrist. It puts them in functional position, and then it's going to abduct the fingers so the fingers don't get stuck in adduction. The cone splint, you're going to put it on the palm, and it keeps the fingers from digging into the palm. So it's kind of like a little foam cylindrical thing that goes under the MCPs on the palm, and it prevents them from digging into their palm and causing skin breakdown. Serial casting, again, we talked about it up here. I'm kind of just explaining more of what it is. Just be careful with skin breakdown when you're doing serial casting, because there's always a splint on. So whenever you take it off, always check. If you see skin breakdown, you have to stop the serial casting until that area has healed. Okay? And if range of motion doesn't increase after 2 consecutive casts, then you just need to stop doing it because it's not an effective treatment. Elbow casting is used for loss of passive range of motion of the elbow flexors. An example of this is the elbow dropout splint. Wrist hand cast is used for loss of passive range of motion again, but this time of the wrist and finger flexors. So those are just a few examples of splints that are used. Wheelchair positioning for that Rancho's levels 1 through 3. you want to pay close attention to the pelvis. Everything starts at the pelvis, okay? So things that you can do to assist with deformities or issues with the wheelchair, you can insert a firm, solid foam board into the sling seat. So the sling seat is the standard seat for the wheelchair. Put kind of a hard insert, but with foam to make it not so hard. And this is going to decrease internal rotation and adduction of the hips. So that posturing that you don't want the hip internally rotated, and you don't want it adducted inside. You're going to use a lumbar support. This will go behind the back to help maintain that natural curve of the spine, or a wedge seat. So the wedge seat can be used, so the specific one I'm talking about is a downward slope toward the back. So it's a wedge that you put on the seat that slopes towards the back of the seat, and it's going to facilitate hip flexion and inhibit extensor tone of the hips and lower extremities. This one is huge. If you have someone who has severe extensor tone and they're having a hard time sitting in the wheelchair because of it, use a wedge seat insert to decrease that tone. And seatbelt can be used over the pelvis to help maintain desired position so they're not falling out. For the trunk, you can use a solid back insert or a firm contoured back to maintain the spine in erect posture. So again, it's kind of similar to the sling seat. It just doesn't give you a whole lot of upright support. So you can put this insert in to help them kind of sit upright with their posture. Lateral trunk supports can be used to reduce scoliosis or lateral trunk flexion. So if you have someone who's kind of laterally flexing to the side with their trunk, this is a good tool to use. Chest straps can be used. This is going to reduce kyphosis, facilitate shoulder retraction, abduction, and extend the upper chest for diaphragmatic breathing and upper extremity use. So pretty much this one is going to go, you want to put Velcro fasteners on it so that they can easily get out of it, so it's not like a restraint. And it's just going to kind of help stabilize their trunk so that they can do more with their arms, and that they can focus on some of the higher level function instead of just focusing on the lower level function of staying upright. For the lower extremities, you can use an abductor wedge. This is going to reduce hip adduction and internal rotation. So it's a wedge that goes in between the legs to cause them to abduct and to reduce that internal rotation. It's going to kind of externally rotate just a bit of the hip. The padded abductor wedge, this is the opposite. It's going to reduce the abduction of the lower extremities. And foot plates. Foot plates are good because they're going to provide that proprioceptive input. So when your feet have a surface that they're sitting on, you can feel them. It's proprioceptive input, and it's also going to facilitate weight bearing in the heels. This is going to help normalize tone. Weight bearing is good for normalizing tone. Upper extremities, you can use a lap tray. Lap trays are good to support the upper extremities. It's also going to encourage bilateral weight bearing in use. So remember, weight bearing good for normalizing tone. Righty, and then last one for wheelchair, the head. You can use a dynamic head positioning device. This is going to help them maintain a neutral head alignment and facilitate head control. So if they're, don't have good head control, this is a good one to use. A contoured headrest. This fits on the back of their head as well as kind of cradles out to the sides laterally. It's going to support the head in a midline position. Forehead straps prevent head from falling forward. And then I really wanted to put this in here. So you want to put them in a slightly reclined position. This is between 10 and 15 degrees of reclining. And this is going to facilitate visual interaction with the environment. However, you do not want to recline them beyond 15 degrees, because what this is going to do is it's going to reduce weight bearing through the trunk and pelvis, and it's going to encourage extensor tone, posterior pelvic tilt, and sacral sitting, which is what all this other stuff was pretty much trying to prevent up here. So don't recline them too far back. It'll cause extensor tone, posterior pelvic tilt, sacral sitting, things that you don't want to see. Other parts of the intervention at this level are dysphagia management and emotional and behavioral management. So since they're, at a pretty low level at this point, you might not get that much of this, but In the next level, you're going to see a whole lot more of it. So let's go back up to the evaluation for Rancho's levels 4 through 8. And just remember 4 through 8, 4 is confused and agitated, 5 is confused and inappropriate, 6 is confused and appropriate, 7 is automatic and appropriate, and 8 is purposeful and appropriate with standby assist, okay? It's going to be similar to the one that we went over for the lower levels, but this one's going to have more of an emphasis on ADL, because if you remember at this point, from level 4 to level 8, they are now awake, they're moving around, they're doing stuff, so you can do more of these functional activities. But do note that with the evaluation process, you're going to have to take breaks because likely they are highly distracted. Remember, one of the key features about Rancho's level 5, confused and inappropriate, is that they are highly distracted. They tend to wander around. And this is where, they have an inappropriate use of objects. So especially at that level and even at level 4 as well, they're going to be highly distracted. So be prepared to take some breaks. All right, first up is the physical status. Similar to what you did before, you're going to look at range of motion, strength, sensation, proprioception, kinesthesia. Now you can look at some fine motor as well as gross motor and total body control. Total body control is just balance, dynamic sitting balance and standing balance. Again, you're going to look at dysphagia, but now you can go a little more in depth. You can look at the oral motor control. Remember that if there's an impairment with oral motor control, you're going to see pocketing of food, okay? That's a telltale sign of oral motor control issues that you'll see a lot with TBI patients. You also want to look for issues with ideational apraxia, and neglect, and you can see this during the during a feeding evaluation. So, do they understand how to use the utensils, which that's ideational apraxia? This is that inappropriate use of objects that we talked about with that with Rancho's level 5. They don't understand how to use a fork. They might use a fork to comb their hair instead of to eat their meal. So that's the example I used before. Or neglect. They might ignore the left side of their plate completely because they have left-sided neglect. You also are going to look at cognition, of course. You want to look at their ability to do functional tasks. So remember, with this eval of this 4 through 8 level, you're going to be looking a lot at ADLs. And for some of the higher levels, even some IADLs as well, meal prep, money management, community skills. Assessments that are going to help with looking at cognition. The Allen Cognitive Level Test, of course. That one's a huge one. The Lowenstein OT Cognitive Assessment, Rivermead Behavioral Memory Tests. The Rivermead we're going to talk about again later on because it also looks at perception as well as cognition. The Coleman Evaluation of Living Skills and the Cognitive Assessment of Minnesota. A lot of these help you out a lot because they have the word cognitive in it. Allen Cognitive, Lowenstein OT Cognitive Assessment, Coleman Evaluation of Living Skills, which is like ADLs, and you think you need cognition in order to do ADLs, and the Cognitive Assessment of Minnesota. So the only one that really doesn't tell you is the Rivermead Behavioral Memory Test, but memory is a part of cognition, so it still links it in some way. For vision, pretty much just do a vision screening. You want to look at, the acuity, you want to look at depth perception, all that good stuff, because that can be affected. Perceptual function, so I mentioned we're going to talk about some more assessments down here. You want to look at their visual perceptual. So this is right-left discrimination, form constancy, position in space, topographical orientation, and naming of objects. Perceptual speech and language is like aphasia and anomia. Anomia is the inability to name objects. Perceptual motor is that ideational apraxia, so understanding how to use objects. Ideomotor praxis, knowing how to use it, but not being able to do the motor movement in order to use it. And three-dimensional constructional praxis, which is as it sounds, like putting things together and building things in a three-dimensional manner. and then body schema perception. The assessments are the Hooper Visual Organization Test, Motor Free Visual Perception Test. I talked about this one in another video on assessments. And then Rivermead again. Remember, we talked about this one. This one's Rivermead Behavioral Memory Test. And then for perception, it's Rivermead Perceptual Assessment Batter. And then again, Lowenstein's down here as well for perception, as well as up here for cognition. All right, so those two are both going to look at cognition and perception. Keep that in mind. All right, you're also, of course, like I said earlier, you're going to look at ADLs and the IADLs. Assessments that are good for these, the OT-ADL, Neurobehavioral Evaluation. I don't really know how to say that word, Aaron Dottier, not sure. It's called the A1 assessment, or the assessment of motor process skills. This one's pretty popular. The AMPS assessment, FIM, the functional independence measure, a lot of people are familiar with, and the Klein-Bell ADL scale. Pretty much, again, the names give you a hint at what they're assessing. Klein-Bell ADL scale, looking at ADLs. FIM, I think people just know that one. Functional independence measure, it's looking at how much assistance a person needs, what they're able to do. The AMPS, again, another popular one. You're looking at motor process skills. The motor process skills needed to complete these ADLs and IADLs, and then the A1. And just be aware that for driving, an individual is going to need to pass both the clinical assessment. So that might be, taking one of these perceptual assessments that we talked about and seeing, is their figure ground intact? Do they understand topographical orientation? That kind of thing. But also, they're going to need to pass the road assessment. So someone could fail a clinical assessment but be able to pass a road assessment and vice versa. So you want to do both and look at both. And that's done by, the road assessment is done by a skilled OT driving assessor. Then we have vocational rehab. This is going to be an evaluation to determine if they are ready to go back to work. You're going to do an assessment in the actual work setting. This is a key point for this. You're not going to do an assessment in a simulated environment or even a test to see if they can do it. You want to go to the actual work setting and see what their ability is, because again, they might not be able to do a simulation because it's not the real deal. So you want to think about TBIs. Everything is about the neural pathways. So if they go back into the environment that they were previously in before when they were working, things might start to click and they can do it a lot more efficiently than they might be able to take a test or do a simulation. You're going to look at their interest, strengths, deficits, recommendations for things that need to be modified within their work environment, realistic goals for the job, and then with their assistance, plan for how they're going to achieve those goals. So you always want to work with the patient to do goal writing and achieving. Psychosocial, this one is big. You have to think they've had a TBI. They know that they don't have the functioning that they had prior to their injury. So you want to look at, what roles did they lose because of the injury? How are they interacting in social environments? How are their interpersonal skills, self-expression, time management, and self-control? So do remember that level 4 through 8, their behavior is huge. So level 4 is confused and agitated. They're often hostile. So you're going to be looking at that self-control and all that. And then even all the way to level 8, they're still going to have low frustration tolerance. So again, still very important. You want to look at social support systems, their ability to form and maintain relationships, resources for reducing feeling of isolation. This is one of the most commonly reported feelings for individuals that have experienced a TBI. They feel like they're alone. Assessments that are good for psychosocial factors are the assessment of communication and interaction skills, occupational role history. This one's specifically good good to look at that role loss aspect, and the role checklist as well. All right, now we're going to talk about interventions for the higher level. So we just did the eval, what you want to look at. I did talk a little bit about some type of intervention things, but I just wanted to kind of put them in there. Now I'm going to go in a little bit more depth about the intervention process. So the first one, for neuromuscular impairment, which you are likely to see, the goal is to facilitate control of the muscles in order to progress proximally to distally. You want to encourage symmetric posture, facilitate integration of both sides of the body when you're doing activities, encourage bilateral weight bearing, again, for normalization of tone, and introduce normal sensory experiences. How can you do this? You can use the PNF or NDT specifically. So remember, the PNF is that patterning. So you have them do patterns of movements in order to get them to a point where they can do the activity fluidly again, because you're helping the brain remember the pathways. The NDT, it's good to use the inhibitory techniques in this technique. So for soft tissue contractures or spasticity, you might want to use this to address functional mobility. So bilateral extremity use, equal weight bearing, and again, tone normalization. Let's see, we got myofascial release as another technique, and then use of physical agent modalities. So just a few examples. This is not all encompassing. I'd be talking for days if it was. Kinesio taping. So this just, you put the little tape on whatever part of the body to provide extra support for the muscles that are weak in that area. A neuromuscular E-stim. Remember that E-stim is going to stimulate that muscle group in order to kind of activate or enhance muscles for strength, sensory awareness, and motor learning and coordination. All right, let's move on to intervention for ataxia. So pretty much for ataxia, your main approach is going to be compensatory. There's not really that much you can do rehabilitative wise. So a few compensatory strategies you can do are adding weight to a part of the body. So for instance, adding like a weighted cuff to the wrist. And what this is going to do is temporarily improve their control when they're doing a task. So if they have like a tremor, that weighted part of the body is going to temporarily improve control. Why do I say temporary? Because as soon as you take it off, that tremor is going to go right back to the same thing. That's why it's not rehabilitative. It's just a compensatory method for a temporary point of time. All right, intervention for cognition. So you want to implement this through the use of ADLs and IADLs. So you want to assess and do strategies while doing ADLs and IADLs. With this population, you're going to see that concrete thinking is going to be impaired. Concrete thinking is just their ability to do think of abstract concepts and things of that nature. And also their generalization skills are going to be affected. So kind of think of interventions within ADLs and IADLs that work on their ability to regain concrete thinking and generalization of their skill. Next up is vision. So you can do an eye patch or prism glasses or even a binasal occluder for treating diplopia, which is double vision. You can also do visual exercises that are going to work on visual attention, pursuit, saccades, fusion, and stereopsis. All right, moving on to perception. So again, we're going to break this down to rehabilitative and compensatory. But unlike when we went over ataxia and compensatory was the main component, for perception, you have a wide range of things that you can do. So a rehabilitative approach for figure ground is to have them repeatedly practice locating objects that are against a similar background. So this might be you place a white shirt onto a white bed sheet and you ask them to find the white shirt on the bed. Okay? Repeated practice that way. Expressive aphasia might be repeated conversation exercises and then give them feedback about incorrectly spoken words and challenge a patient to express the words that they meant to verbalize but weren't able to. This is also going to be done by the speech therapist as well, but I just wanted to mention it here because the OT can work on it while working on, ADLs and IADLs and things like that as well. Intervention, rehabilitative approach for apraxia. So remember, I told you there aren't that many, but you can do some hand over hand exercises. The patient, this is, again, neural pathways are key. So like I said with the kinesthetic approach earlier, do the movement with them hand over hand so their body can relearn how to do it. For neglect, you're going to encourage them to use the neglected extremity in all ADLs. So encourage them to incorporate that side of their body. And then another thing you can do environmentally is rearrange the room. So move the TV, move the bedstand to that affected side that they're neglecting. And that way they have to acknowledge that side, or else they're not going to be able to get to those things. All right, moving on to compensatory approaches for the same exact things. So for figure ground, instead of making them find something on a background, you're going to fix the background. So you could rearrange, say, a kitchen drawer and put things in easily identifiable areas, put them in categories so that they can easily be accessed without much difficulty. For expressive aphasia, you can use a chart with letters, words, and or pictures of things that they commonly might need to tell you. So a chart with a toilet on it, or some food, so that they can express those common things to you. For apraxia, you can do some following steps through visual interpretation of sequentially depicted pictures or words. So pretty much just have how to do it in either pictures or words step by step, so the person can just follow that and be able to complete the activity. So for dressing, you might have some pictures of step by step what they need to do in order to get their shirt on. And then for neglect, okay, I want to mention you only really want to use a compensatory approach for neglect if the patient is not demonstrating significant improvement when you did the rehabilitative stuff. So in order for them to engage in an activity over time, you're going to need to do compensatory if they weren't able to achieve much return with the rehabilitative approach. So something you can do, if they're reading, place a colored border on the neglected side of the book, and this is going to cue them to scan. So scan for the red line. And you can use different anchoring techniques with other activities as well, by telling them to scan until they see the whatever marker you've set for them. Okay. Behavioral management. Remember I said this one is a biggie for 4 through 8 level because you do have a lot of behaviors. You can do environmental interventions. So change the environmental features. Because you want to try to encourage appropriate behavior. You want to get rid of the unwanted behaviors, and above all, you want them to be safe. So because at this point they're highly distracted, and at level 4 they're highly irritable, you want to try to reduce as much stimuli as you can. Take the TVs out of the room, the radio. Don't put them with a roommate. When they're doing therapy in the room, do it with just you and them, because it's going to decrease some of those behaviors, because they're not going to be sensory overload. You might use a wander guard, so if they try to wander off, the staff will be alerted. Different types of walkie-talkies or pagers for elopement risk. And then in some cases, you might even need to assign a one-to-one aid for their safety. For some interactive interventions for behavior, you pretty much want to do everything consistently throughout every person in the hospital. So, speak calmly and concisely. Never over-explain something, because they might not be able to understand, and you're just going to confuse them and frustrate them even further. For a behavioral management program can be implemented if it needs to. And what this is if they do something, if they have a poor behavior, they're going to get a natural consequence in response to it. So this is trying to encourage them to react appropriately so they don't lose some of the things that they want, like community recreation privileges. All right, almost done with this. Dysphagia and self-feeding is another intervention that now you can engage in a little bit more, like I said earlier. So you can use adaptive equipment because you might see poor strength, coordination, perceptual deficits. Just a few examples I listed: a rocker knife, plate guard, non-spill mug. One intervention you can do for someone with impulsivity is after every bite of food that they take, they have to put their utensil down. This is going to cause them to have to slow down, and it's going to reduce the risk of aspiration or choking because they're able to thoroughly chew their food. Functional mobility, rehabilitative approach. You want to primarily use a rehabilitative approach. Again, the compensatory can be used if you're not seeing significant gain. Then obviously they need to be able to functionally get around. So that's when you'd incorporate some compensatory approaches in order for them to do what they need to do. Mobility is obviously primarily focused on by the PT, but when it comes to functionally, we can do it too. So by functionally, I mean like walking to the bathroom, that kind of thing. You just don't want them to rely on a compensatory approach. You want them to rather regain the ability if possible. All right, transfers, bed mobility, wheelchair mobility, functional ambulation, community travel, kind of helping them figure out how to do all these things effectively. Community travel is going to be a little bit closer to the discharge stage, obviously. All right. Now, home management. You want to start working on this once they've got the self-care and the functional mobility a lot better. It doesn't need to be completely independent, completely achieved, but you want to get as close to it as you can, and then start working on some things like meal prep, cleaning, money management, things they'll need to do when they go home. For community reintegration, this is helping between the transition from the hospital to community. An issue that has been often documented is when people leave the hospital setting and go home, they kind of fall apart sometimes because the hospital is so structured and they have so much support. And then when they leave and they go home back out into the community, they don't have that support sometimes, and they don't have that structure. And you can see a lot more deficits and a lot more issues that they're going to have. So you want to try to prepare them early for this. And at advanced levels with individuals with TBIs, you can go out on community outings with the OT. For psychosocial skills, the goal is after you transition out of acute. So I'm talking about when you are at home, or if you're doing outpatient therapy, that kind of thing. You want to see, like I said earlier, the roles that they lost, activities that will support the roles that they lost, identifying rites of passages. So just big events in their life, like maybe getting their driver's license that they missed out on, or graduating from high school that they may have missed out on. And then you want to take these things and facilitate use of adaptive compensatory strategies and new learning in order to achieve as much as you can of what they lost. And just a side note, group intervention can be really helpful for these patients because they're interacting with other people that have gone through something similar. They can kind of problem solve and give each other some advice. I didn't write too much about this one, but you will sometimes see substance abuse when someone leaves the hospital, especially if they had substance abuse prior to getting the injury. They'll usually go back to it. So just to have that in mind. Discharge planning, you want to be thinking about this from the first day that you get them in the hospital. So discharge planning is something that you think about throughout. You want to think about home safety evals, what equipment they're going to need, getting it ordered, and of course educating the family and the caregiver if necessary, if they have a caregiver. And then vocational training, again, I said if they're ready to go back to work. And then I just put a few extra notes down here about the specific assessments I talked about and some that I didn't. So the JFK coma recovery that I talked about for the first level 1 through 3, This is going to help you document improvements, like I said earlier. This one I didn't talk about up before, but it's just another ADL assessment that measures a person's independence in doing ADLs. This one I also didn't talk about. Contextual memory test. It's a cognitive assessment, so it's going to specifically look at their memory. All right, so I just wanted to mention those few things, so that way if we see them on the test, we'll be able to know that they can be used with this